8 years old. That age, there's that energy that goes from one thing to the next thing to the next thing. And Mom Lemitra Scott is keeping up.
I want to go higher than this.
I feel like you're going to fall off because I do.
It's a perfect day at the park. But chasing after that 8-year-old energy, Lemitra says she knows what to do when the sun makes the day very hot. There have to be moments away from the swings, away from the slides for her son, Ricky.
I have sickle cell and it's called SS type.
Sickle cell disease is a genetic blood disorder. It causes excruciating pain, can lead to organ damage, and it involves taking regular medications. It involves staying hydrated. If you fall short of executing any one of those areas, that could land you in the hospital. I have to make sure that he knows to take breaks. Outside, it's hot. Getting dehydrated can trigger a sickle cell crisis.
It feels like I just want to scream, but I don't.
Ricky is a tough kid, but his mom remembers how scary it sounded when she first heard his diagnosis.
My first reaction was, oh my God, what can I do to save my son?
In doing research and getting answers, Lemitra says people weren't talking about sickle cell disease enough, with it impacting minority communities. According to the CDC, sickle cell disease happens in 1 out of 365 Black or African American births. 1 in 13 Black or African American babies are born with the sickle cell trait that can be passed to their children. And Lemitra has a new concern for people with sickle cell like Ricky: a national severe blood shortage.
People with sickle cell disease depend on blood transfusions regularly. When they go for a transfusion, the blood may just not be on the shelf.
The Red Cross says part of the issue is due to medical centers needing a higher supply of blood, because elective surgeries and organ transplants that were delayed during COVID are happening again now.
During the early weeks of COVID last year, more than 1,500 Red Cross blood drives were canceled. But this mom knows what to do. You see, Lemitra is Doctor of Pharmacy Lemitra Scott, and she's taking her background and using it toward this, creating the Breaking the Sickle Cell Cycle Foundation. The foundation educates healthcare providers and families about sickle cell, and now it's reaching out to cities returning to normal life and asking for people to give.
And we really, really need the people that are in the minority populations to get out and donate blood.
In those painful moments, Ricky says his mom knows what to do.
I get my medicine, I take a break, I get a drink of water, and I sit down for a minute.
Playtime again. This 8-year-old with so much energy will tell you, no matter what it is, his mom always knows what to do.
He wants kids and a whole bunch of people to survive.
In Nashville, Tennessee, I'm Forrest Sanders.
I would like to take a moment of personal privilege. I think that the next person that's coming up is our state president. I know her personally. I know her as a friend. I know her as a leader. I know her as a mentor. I know her as a preacher. But I know her mostly as just an average person. A person that loves God, loves her people, and loves the NAACP. And I would like to introduce some and present to others our state president, Mrs. Gloria Jean Sweetlove, national board member of the National Association for the NAACP. Madam President, you can have remarks at this time.
Thank you, VP Garland, and thanks to each of you. I'm excited about this. As I said to VP Garland, I've been Zooming all day. We've been doing some interviews nationally to try to fill some positions, but I thought this was critical enough. If I could take a few moments and just come by and say hello. As some of you have seen crossing the back of my screen, my 2-year-old and 4-year-old niece and nephew who live upstairs always come into my study when I'm doing a Zoom. It's just a thing that they do. But I'm excited about your concern to see you guys doing something on sickle cell. I think it's one of those things that we don't talk enough about. I don't think we share it enough in our community, how critical it is. Some of you know and some of you don't know that one of those beautiful grandnieces of mine who was a Harvard graduate just died from sickle cell about 3 weeks ago. So it is very personal to me. So I just want you all to know you can count on us to do whatever we can to try to push the button and make sure that sickle cell comes to the top of those diseases that we need to watch, and we need to make sure our community is aware of them and doing what we can to them.
Good evening, ladies and gentlemen. My name is Ursula Layton, and I'm the chairperson for the Health Committee of the Clarksville, Montgomery NAACP Branch 5582. I will be introducing you to our guest panelists, and then they will do a Q&A in regards to sickle cell. So hopefully you will learn a lot in this forum about the sickle cell that you were not aware of. So first up, we have Dr. A.G. Dr. A.G. is a professor in the Department of Obstetrics and Gynecology and Internal Medicine at Meharry Medical College and the adjunct professor in the Department of Medicine, Division of Hematology, Oncology at Vanderbilt University. She is the director of the Meharry Sickle Cell Center. Dr. A.G.'s research interests are in sickle cell disease and women's health, and her clinical interest lies in the diagnosis of hemoglobin disorders, for which she is consulted nationally and internationally. She directs the State of Tennessee Newborn Screening Hemoglobin Diseases Confirmatory and Reference Laboratory housed at the Meharry Sickle Cell Center. Ladies and gentlemen, Dr. A.G.
Thank you very much, Ms. Ursula, for the kind words and for the introduction. I'm very excited about participating in the forum today, and I wanted to thank you, Mr. Garland, Ms. Sweetlove, and Ms. Morris for your kind invitation.
Next we have Dr. Richard Martin III. Dr. Martin is an assistant professor of medicine and hematology oncology at Meharry Medical College and serves as co-director of clinical oncology trials and clinical medical director of the Meharry Sickle Cell Center. Dr. Martin's practice and research interests include improving equity in access in cancer screenings and trials, promoting interdisciplinary health education programming, and facilitating community academic partnerships to enhance awareness and access to emerging sickle cell treatments. Ladies and gentlemen, Dr. Richard Martin.
Hello, everyone. I'm so grateful, honored to be here. Thanks to the NAACP for inviting me. And boy, I'm looking forward especially to the Q&A and to getting questions and hearing from people with sickle cell disease who are living with the disease, finding out what's important to you. So I'm very excited to be here this evening. Thank you so much.
It was hot back here and cool in the front, right?
Dr. Martin. Next, we have Ms. Lucon Cooper. Ms. Lucon Cooper is a photographer whose life reflects the following quote: "Be like a tree, stay grounded, connect with your roots, turn over a new leaf, bend before you break, enjoy your unique natural beauty, and keep growing." With roots in Mississippi, Lucon spent most of her life in Chicago, working hard while learning to thrive with sickle cell. Despite the doctor and she didn't have children, she gave birth to 3 healthy children, showing them the value of rebounding after divorce, reinventing herself by getting another degree in film, and giving back by being on the board of various women's organizations and breaking the sickle cell cycle. She now resides in Murfreesboro, Tennessee, and enjoys spending free time with her granddaughter. Ladies and gentlemen, Ms. Lucon Cooper.
Hi, guys. Thanks for having me.
Next, we have Dr. Lemetria Scott. Dr. Scott is the founder and CEO of the nonprofit organization Breaking the Sickle Cell Cycle Foundation, Incorporated, a pharmacy consultant and mother of a child with sickle cell disease. Dr. Scott has worked in pharmacy for 20 years. Over the last 10 years, she has worked in managed care pharmacy, assisting organizations with developing strategies to provide cost-effective pharmaceutical care and improving patient outcomes. As a caregiver and healthcare professional, Dr. Scott understands the challenges associated with treating complex conditions like sickle cell disease. In 2015, Dr. Scott decided to leverage her experiences in managed care and community pharmacy and founded a nonprofit for sickle cell disease, which focuses on promoting community awareness, education, and prevention of sickle cell disease. Dr. Scott has led numerous outreach efforts to educate the community and other healthcare professionals about sickle cell disease. Dr. Scott has been recognized for her involvement in sickle cell advocacy. She was featured in the inaugural edition of Pharmacist magazine, a magazine that celebrates women in pharmacy. Featured on the CDC's website, real stories from people living with sickle cell disease. And she is also a Power Moves Award recipient, an honor that is awarded to ordinary people doing extraordinary things in the community. Okay, sis. Dr. Scott contributes to student pharmacists, academic development, and conducts didactic presentations on sickle cell disease at both the University of Tennessee and Lipscomb College of Pharmacy. Dr. Scott obtained her doctorate of pharmacy degree from the University of Tennessee College of Pharmacy, and she also holds a Bachelor of Science degree in biology from the University of Memphis. She believes patient engagement and inclusion is key to developing best practices for providing care to sickle cell patients. Her contributions have been published in the Journal of Healthcare for the Poor and Underserved. Ladies and gentlemen, Dr. Scott.
Well, thank you, Miss Ursula. I'm sorry that I gave you a whole long biblical speech almost for an intro, but I do thank the NAACP for the invitation to speak today along with our other panelists here, Dr. Martin, Dr. Aguinaga. We actually work very closely on other projects in addition to what we have going on here now. So thank you all again, and I hope that you enjoyed the video that you saw previously, because there is a significant need in the community right now for blood donations for sickle cell patients. Thank
you. You have been introduced to the panelists. They will now each show a 10 to 15 minute presentation. Now that you have been introduced to the panelists, they will now go into a 10 to 15 minute slide presentation, starting with Dr. AG.
Thank you. I will share my screen.
You are now host, Doctor.
Thank you. Am I now?
Yes, ma'am.
It's not showing my screen.
You should.
Let's try again.
There you go.
to talk today in this forum a little bit about sickle cell history, how the mutations, or the mutation, the origin for the disease, the distribution in the world, and the definitions of sickle cell disease, the different types, and sickle cell trait. And then I'm going to mention briefly the tests that we do, and then I'll be happy to entertain any questions in the chat when the time for questions come. I have this picture as the first slide because right now sickle cell disease, as you know, has a changing face. We can find them not only in African Americans, but Hispanics, Native Americans, Southeast Asians, or Amer-Asians, and different population groups. I have no disclosures. And the first time that sickle cell disease was discovered in the Western world was in 1910 by Dr. James Herrick. He had at the University of Chicago his clinical practice, and a student, Mr. Walter Clement Noel, a student from Grenada who was a dental student at the University of Chicago, presented to his practice with fever, jaundice, pain, and Dr. Herrick gave the case to his resident, Dr. Ernest Irons. And it occurred to Dr. Irons to take a blood sample from Mr. Noel and put it under the microscope. And to his surprise, he saw something that nobody had seen before. He saw these red blood cells that were abnormally shaped. They looked like croissants or bananas, or like the instrument, the sickle, the agricultural sickle. But it was not until 1922 that the term sickle cell was coined. However, 50 years earlier, we will see reports in the literature in the United States in runaway slaves that describe this sickling that nobody knew what exactly it was, or the absence of spleen in runaway slaves. So, however, it was not until 1910 when sickle cell disease had its official discovery in the Western world. However, sickle cell disease has been in Africa. Recently, we have known that it has been for over 7,300 years in Africa. And through whole genome sequencing, it has been found that they have passed 259 generations of sickle cell disease, which corresponds to over 7,000 years in existence. And also, it has been found that there is a single origin, because for several decades, the belief was that there were 5 possible origins of the disease in Africa. But now we know that there was a single origin, and this origin can be correlated with specific haplotypes, which means specific patterns on the DNA surrounding the sickle cell mutation that are named after geographical regions in Africa, like, for example, Central African Republic or Bantu, Cameroon, and also regions in Asia, Saudi Arabia, India. If we look at the distribution of the sickle cell mutation in Africa, here we can see all these pockets. And if we look at the distribution of Plasmodium falciparum, the malarial parasite, we see that they mimic each other. So somebody, Dr. Haldane, postulated the hypothesis that probably sickle cell mutation arose as a protective mechanism against malaria. And here we can see regions that correspond to the specific patterns of haplotypes, like Central African Republic, Senegal, Cameroon, Benin, Saudi Arabia, India. So how do we define sickle cell disease? Sickle cell disease is defined by the presence of sickle hemoglobin inside the red blood cells in a concentration greater than 50%. And if it is less than that, most likely it will be sickle cell trait. Here we have the genes, and these are our chromosomes. We have 2 pairs of chromosomes for each number. For example, we have 2 chromosomes 11, we have 2 chromosomes 16. In chromosome 11, here we have the beta globin gene. This is the one that bears the mutation for sickle cell. 2 alpha globin genes and 2 beta globin genes products, which are the globin gene chains, will form the hemoglobin molecule. The normal hemoglobin is called hemoglobin A, which stands for normal adult hemoglobin. But when you have a mutation here at position 6 in the beta globin chain, then it will give rise to sickle hemoglobin. And if you have 2 alpha globin chains and 2 beta S globin chains, you will have sickle hemoglobin. In this picture, we can see the mutation, GAG to GTG, and usually at position 6 of the beta globin chain, we have glutamic acid. But because of this single nucleotide substitution, glutamic acid is changed to valine, which is another amino acid. And only this difference in one amino acid in one nucleotide completely changes the biophysical properties of the hemoglobin molecule, becoming sickle hemoglobin, which has less solubility, less oxygen affinity. And therefore, under conditions of deoxygenation, this hemoglobin can sickle, producing fibers and distorting the shape of the red blood cell. And these cells, or sickle cells, tend to occlude the microcirculation, producing vaso-occlusive pain and interfering with the delivery of oxygen to the tissues, producing tissue ischemia and therefore pain, and in some instances, tissue infarcts. So, how the sickle cell disease that originated in Africa came to the Americas? How did it come to the New World? Well, we know that since the mid-1500s to the mid-1800s, about 15 million people came, against their will, to the Americas, to Europe, North, Central, Caribbean, and South America. Most of the people came to South America, to Brazil, about 5 million people, about 4.5 million to the West Indies in the Caribbean, about 500,000 to Peru, where I am from, 0.2 million to Central America, and 500,000 to the United States. And therefore, that's why we see sickle cell disease in the United States, in Central and South America, besides Africa. And as I explained earlier, we also see in Southeast Asians that are also called Amerasians, that usually had one of the parents African American and the other parent Southeast Asians, and they give a specific type of sickle cell disease. We have different types of sickle cell disease, and I'm just going to define them. When you have the 2 beta S globin genes mutated with the same beta S mutation, you have the homozygote state, which is called hemoglobin SS, sickle cell anemia. About half of the cases in Tennessee of sickle cell disease are sickle cell anemia. And then we have other types of sickle cell disease, which are usually the beta S globin gene giving rise to the sickle hemoglobin, and then another hemoglobin variant, which is produced because of another mutation on the beta globin gene. So we have SC disease, or SD disease, or SE disease, and hemoglobin SA, or is also called sickle beta thalassemia. And we also have sickle beta zero thalassemia. So those are the types of sickle cell disease. And then in the case of sickle cell trait, we have one normal hemoglobin, hemoglobin A, and the other hemoglobin is mutated and is sickle hemoglobin. So that's hemoglobin AS, and it's not a disease. It's just a heterozygote or a carrier. Sickle cell disease and sickle cell trait are quite prevalent in the African American population in the United States. And depending on the states, we can have 8 to 14%. Sickle cell anemia is 0.3 to 1.3% in the African American population. Hemoglobin SC disease, 0.1 to 0.25%. And sickle beta thalassemia, which is the SA type, is less than 0.05%. If we look at the numbers right now, like Dr. Scott mentioned in her video, 1 out of 13 people in the African American community carry the sickle cell gene, and they are sickle cell carriers, which is also known as sickle cell trait. 1 in 365 African American births are born with sickle cell disease. And then we have other types of sickle cell disease in lower amounts. And then not only African Americans, as I mentioned before, it can be found rarely in Caucasians. This is Hispanics from California, but Hispanics in the eastern United States is 1 in 1,100. In Asians and in Native Americans as well because of that mixture. And as I said, it is prevalent in people of Mediterranean, Middle Eastern, India, Caribbean, and South American descent. Now, what is sickle cell trait? Sickle cell trait is a heterozygote state, and we can define it by the presence of sickle hemoglobin in the red blood cells in an amount of 35 to 45%. This is typical, and it's always less than 50%. If it's more, it will be sickle cell disease. Now, right now, the incidence at birth, and this is by a 2010 study reported by the CDC, is about 15.5 cases of trait per 1,000 births. And about 6.9 births in Hispanics for sickle cell trait, 73 in African Americans per 1,000, and 2.2 per 1,000 in Pacific Islanders, and 3 cases per 1,000 in Caucasians. How do we test for these disorders? As Ms. Layton mentioned, I specialize in testing at the newborn level, and we can test for these disorders by using 2 types of tests. All can be summarized in 2 types, those that look at the protein or those that look at the mutation per se, at the DNA level. At the protein, we will look for the presence of sickle hemoglobin and the other hemoglobin variants that can accompany this mutation. And by the DNA testing, we look at the specific gene mutations in the beta globin gene region. We can test at different levels in life, different stages, as early as before pregnancy by testing the embryos, or at the fetus by different methods, or at the level of newborn. And then the same techniques for newborns are used to test adults. Thank you very much. I will stop sharing.
Okay, who is the next speaker?
I will go next if you can make me the host, Dr. Martin. Thank you, everybody. Thanks, Dr. Aguinaga, for the great opening setup there on kind of the history of sickle cell. I'm going to cover a lot of what Dr. Aguinaga said, but the emphasis is going to be a little different towards more of the clinical aspects that you all may be wondering about. I saw some great questions. So understanding how sickle cell disease causes its symptoms. Can you guys all see my mouse here, my cursor there moving on the screen? Okay, great. So I won't have to use a laser pointer. So, so first, again, kind of covering a little bit what Dr. Aguinaga talked to. I'll be starting kind of small on the genetic level. We're going to get bigger to the cellular level, and then really start thinking about the whole person. Because as a doctor, I always tell my patients, I don't treat diseases, I treat people with diseases. So I think that's important, first and foremost, to think about the human being sitting in front of me. But let's kind of recap some of the things from that first presentation, which is on the left-hand side here. You'll see this is when we're in mom, when we're still a fetus. And when we start out, we make these proteins called hemoglobin, which is what delivers oxygen to our body. And when we're still in the womb, that protein, that thing called hemoglobin, is a combination of alpha, and down here, if you follow this line back, this is gamma. These two together form fetal hemoglobin, which is actually something, if anyone has heard of the drug hydroxyurea, tries to help us revert back to this type so that we're not making this combination here, which is what typically in adults is alpha and beta. And again, Dr. Agonago is saying that it's this beta that has just a tiny mutation in it, which I'll show in the next slide, that causes this protein over here, the hemoglobin, to have some changes in shape, which can be harmful. The instructions come from mom and dad, and we've got the alpha up on the top here, and that comes, you get 2 copies from mom to make the right, and 2 copies from dad to make the correct one. But when it comes to the beta that needs to partner with it, you only get 1 chance to make it right from mom and dad. Having 1 copy that's the sickle type will get you trait. Having 1 copy of both can get you sickle cell anemia, or one of the variants that can still be sickle cell disease. We'll talk about that in a moment. So again, this is just a recap that this entire disease really stems from just 1 tiny change in the instructional code. So inside the cells, imagine we have a library and we have our DNA. So this is the single point right here in point number 6 from A to T. And what that does is if you're a student in the library, you can't take the books out, but you need to be able to make a copy. You make this copy that you take home with you called the RNA, and that's what actually then does the job to make our proteins. So once you take this out, it makes a protein that's slightly different because the instructions weren't right. So instead of making this type of amino acid, which is just 1 tiny piece of the protein, it changes it to something called a valine. And it's just that 1 little thing that changes the entire shape of the protein. And it's that change in shape that makes it prone to clumping when it's under high levels of stress, meaning low oxygen, sometimes dehydration. And that's shown here, where if you have enough of these types of clumping hemoglobins, you get these long strands, again, these fibers, and enough of those clumping inside the cell are going to twist it around and change the shape. And that's where we get that classic sickle shape. Now, very importantly, if someone had 1 copy, again, from mom or dad, but then the normal other copy, you're going to have a mix. And so you still might have enough of the normal copies floating around that don't turn into the fibers, that enough of your blood cells are going to be normal in shape and not have as many types of pain crises, maybe not have as many symptoms. But under extreme stress, you can still get enough of these to where it can cause a lot of problems. And especially in people we'll go over later, if you go to high altitude, if you're a high performing athlete, particularly athletes that are doing twice-a-day football practices here in the South, you can really get into trouble and maybe not even know that you had trait status, and it can be lethal. So knowing your status is very important. Speaking of differences between trait, sickle cell anemia, sickle cell disease, names matter, being right in our definitions matter, and so these aren't necessarily interchangeable. Sickle cell disease is an all-encompassing term, meaning that at least one of them has the sickle S. If you look down on this row, every single one of these has the S, and again, that's at least 50%. But you can have normal copies of the other one. If you've got a normal copy here, that's the carrier. If you have the double S, that's that classic sickle cell anemia disease. But you can also have ones where you don't make good copies or don't make another copy at all. That's these things called thalassemias. Or you can have other types that aren't the S, but still are an incorrect way of making the hemoglobin, like SC or SEDO. But very importantly, I wanted to talk about this. And again, in Q&A, if anybody wants to go over the history of disparities and some of the ugly racism that contributes to this disease, wanted to at least touch on that to say that while we can call people having sickle cell disease or anemia, we should really not ever use the word sickler, nor should you ever accept anybody calling you that in the emergency room or anywhere else. And please, reach out to me if anybody in this community in Middle Tennessee is saying anything like that. There have been studies, 2013, looking at ER doctors that use that term. And in a broader questionnaire, they had a lot of other kind of negative stereotypes about people with sickle cell disease and people who are Black. And similarly, a follow-up study showed that patients felt like they had greater mistrust towards providers who use that term with them. So again, I'm here to treat the person, not just a disease, and we want to be respectful with the words that we use. So now I want to talk a little bit about how those changes in the red blood cells actually cause you all this pain and all the other symptoms. We start here with a normal shape, and again, if these sickle cell hemoglobins, the kind of things that are inside of it, start to clump, it's going to change the shape into this. Now, these aren't going to be able to go through so much. They're going to get stuck. But actually, that's just one of the mechanisms. You can think that if you're twisting something around, kind of think of it like the person who makes a balloon animal. Well, if you twist enough, the balloon is going to break, or the red blood cell is going to pop open and break. And that's something we call hemolysis. When it does that, all of the things that are inside that red blood cell get released into the blood, and a lot of those are inflammatory, damaging to the cells. They cause just a lot of extra pain, and then they also stimulate the immune system, which is this last piece over here. The immune system comes in, and those immune system cells are big, they're sticky, they're inflammatory. And before you know it, you get a lot of scarring from the inside of your blood vessels. They become hard, tight, it's hard for blood to get through them, and without blood flow, pretty much you're depriving your body of oxygen. It's just gonna hurt. And if you lose blood flow to the brain or the heart or another organ, it's not going to work very well and could have permanent damage. And that's this next slide. So starting out, again, with where a blood vessel branches off here, you can get places where the skinnier and skinnier it gets, you get these blockages, and then you lose blood flow to the organs. And those critical ones like our brain, our heart, that's where we end up getting in the lungs and in the heart, things like acute chest syndrome. If it goes to the kidneys, you can knock out kidney function, and that causes something called nephropathy. Or you can get blockages to the bones, and even the bones, parts of the bones, even require a blood supply, and you get really nasty hip pain, and can actually lose the bone in those joints and have to get hip replacements. So there's so many different parts of the body that are impacted by this disease. It can be different for everybody, even within the same type. But then again, there's different types of sickle cell disease, and even the different types have different things that can be more, some of them are more eyes and bones, some of them are more kidneys. Everybody's a little bit different. So the most important part is knowing your disease, working with a provider who understands the entire you. This slide is really great things as far as what can you do to avoid your flares, to avoid your triggers, and kind of starting here on the top left. Again, this is high altitudes. So if you're visiting, Denver, Colorado, or any place in the US or even internationally, the higher you go, the less oxygen is in the atmosphere, is in the air. So it means that not as much is going to get into your blood. And it's, again, those low oxygen conditions that cause the hemoglobin to change its shape and form those clumps. Anytime your body has to work harder, whether it's fighting a fever, infection, could be a virus, anything like that, where it's that heat is actually your body internally working harder. It's going to require more fuel, it's going to require more water, it's going to require more oxygen, and that's a classic time when you can flip that switch and start getting into a crisis. Similarly, just like an infection can cause us to work harder, we can want to work harder, whether that's athletics, gym, anything else, but under extreme exercise, the same thing can happen. And again, whether it's exercise or just a hot day, it's really hot. I'm from the Pacific Northwest where it's 110 right now, and just dehydration alone can do this. Similarly, bleeding or poor sleep, this is just a respectful image meant to represent a woman maybe going through her period, but bleeding from any source, anemic in general, can sometimes precipitate these. And then lastly, changes to medications, or whether you're able to afford or have access to your sickle cell medications, or you start a different medicine that may interact, and maybe Dr. Scott would be able to speak to that with her pharmacy expertise. But any changes really of anything that's going in or out of the body can be a potential trigger. So knowing your triggers is really important. And then the last couple slides is just taking a step back. Here's all the different parts of the body where sickle cell can impact. But I always think about that and what it means for, again, someone's potential for their well-being, their happiness, their pursuits in life, their ability to maintain relationships. And I just think that, you know, for folks who are born with this disease, just the struggle of having an entire life where living with this disease becomes your one shot at life, and what a challenge that can be, how overwhelming that can be. And so I think just taking a moment to appreciate that, validate it, and let people know that, you know, if you see a sickle cell provider, hopefully someone like myself, they respect and understand that, and really think about treating the whole person, which first and foremost begins with listening, why I'm excited to take questions and answers today. And then just acknowledge and respect, think comprehensively, and don't also just assign everything to sickle cell disease. I had a couple of patients actually today in my clinic that, you know, you still want to keep an open mind, because folks with sickle cell disease still get cancers, they can still have iron deficiency anemia, they can still have everything else that everybody else gets. So in some ways, you know, folks with sickle cell disease are very special, and in some ways they're just like everybody else, and they need to be treated in both ways. So that's basically kind of an overview there of symptoms. Happy to take questions again at the end. Feel free to put them in the chat, and with that, I will exit my sharing. And I believe we're going to our special guest. Is that correct?
Dr. Scott.
Ms. Cooper?
Now, I think I'm going on next, and then Ms. Cooper is coming after.
Oh, great.
Okay. So, I'm the host. Okay. All right. Can everybody see my screen?
No.
No, you can't see it? Okay.
No, we can't see you. No.
Okay. Well, it might help if I push share the screen.
There you go. We can see it now.
You can see it now? Okay, let me get in the presenter view. All right. So today I am going to talk to you about treatment options in sickle cell. So you've heard from Dr. Aguinaga about the history, a little bit about pathophysiology. You heard from Dr. Martin on exactly how sickle cell disease affects the body. It's a blood disorder, but also it can affect different organs and just overall quality of life and functioning of the body. So I'm going to talk to you a little bit about treatment options that are available for sickle cell. And we talked a little bit about disparity when we first began, and we were talking about how this disease affects African Americans, people of minority populations. And with that being said, a lot of the treatment options that are available for sickle cell disease have been very far and few between, with the exception, I would say, of the past 5 years. Prior to that, there really weren't any widespread treatment options available for sickle cell disease. So people who had these excruciating conditions were left to basically fend for themselves outside of having a blood transfusion. In the late 90s is when hydroxyurea came to play. And that is a medication. And I'll give this little slide here as an overview of all the meds that we're going to talk about. So hydroxyurea was the very first one. Late 90s, it came into being that it was actually very effective for the treatment of sickle cell disease. And that's because it actually flipped the switch back on to cause the body to create more or hemoglobin F. You saw what Dr. Martin and Dr. Aguinaga alluded to in their presentations about the different forms of hemoglobin that are produced. Well, when your body turns back on that hemoglobin F type, it does not contain that beta globin gene. So therefore it doesn't sickle. So therefore you don't have that to run that risk of having sickle cells. So that's the importance of hydroxyurea. In addition to increasing that hemoglobin F, in doing so, it reduces the pain that's associated with sickle cell disease. It has been shown to reduce hospitalization. It actually increases the time between pain episodes. It reduces the need for having a blood transfusion, and it reduces the incidence of acute chest syndrome. So this is something that if you had an ideal medication to come to play, this is what you would want it to do. You would want it to cover all of these bases. The problem is that one, it doesn't really work for all the different types of sickle cell disease. As you saw in the previous slides, there are different variations depending upon where you get that amino acid substitution in that hemoglobin beta chain. Depending on where it occurs, you can have a different type. Well, hydroxyurea, it really works for those people who have sickle cell SS type or either a sickle beta 0 type. For all of the others, SC, SD, SE, it may work, but what we have seen is that it's more beneficial for people who have SS or sickle beta 0. In addition to the fact that it doesn't work for all types, there are some pretty heavy adverse effects that can be associated with hydroxyurea. That is why it is so important that if you were to start this medication, that you have to take it every day. It takes about, I would say, 3 to 6 months before your body fully begins to make that hemoglobin F that you're wanting to see. So a lot of people may stop therapy prematurely by thinking that it's not working. You just have to stick with it. In addition to that, you also have to make sure your blood counts are monitored very frequently. It starts off every 2 weeks when you start the dose, and then once your blood levels are at a stable dose, then you can go to every 4-week monitoring. But every time the dose changes, you have to go back to that monitoring schedule of 2 weeks and 4 weeks. This is very, very, very important because hydroxyurea is a chemotherapeutic agent. And we all know that medications that are chemotherapeutic, their whole intent is to decrease blood production or decrease blood cell production because you want to stop a cancer cell from growing. In sickle cell disease, there is not a differentiation between sickle cells and normal cells. So therefore, you have something that's called myelosuppression that can occur. That means you have decreased blood counts in the body. So you have a decrease of your white blood cells, decrease of your red blood cells, decreases of your platelets. All of those cell lines are crucially important to sustaining life because if you don't have enough of any one of those, then you could land in serious trouble. You could have anemia, you could bleed to death because you're not clotting, or you can develop serious infections because your immune system is pretty much wiped out. So that's why it's so important that if you're going to start hydroxyurea, there are certain things that need to be understood prior to starting, and you also need to know what to expect once you have started it. Moving on to the next medication that is available, because like I said, hydroxyurea is not a cure-all. It's the best that we had at the time, but in 2017, thank God, there was another option brought to the table. So in 2017, we got Indari, which is also referred to as L-glutamine. L-glutamine is an amino acid that is indicated to reduce acute complications like pain from sickle cell disease in patients as young as 5 years old up to adult. So what the L-glutamine does, it actually restores the antioxidant stability inside the red blood cell. So you saw from Dr. Martin and Dr. Aguinaga's reports of how the red blood cells can hemolyze or break apart, and then that content that wastes out or that spills out into the blood, it actually is very inflammatory. So what L-glutamine does, it actually helps to stabilize the cells that are sickle so that they don't break so easily, but it also stabilizes the cells that are in the surrounding areas so that they are not so subject to the intracellular content that had fallen out, so that they are pretty much not affected by the spillover, basically. So therefore, they don't break apart. So what Indari has done is that it has shown to reduce acute complications like pain. It reduces hospitalizations, and also it increases the time between pain episodes. So what that means is that the people who may have experienced pain maybe once or twice or a week, that has gone down to maybe it's once or twice a month. So it just varies between people. And this one is also available for the treatment of all of the variations of sickle cell disease that could be out there. So not limited to just SS. This medication actually is, like I said, it's amino acid. It does come in a powder formulation, and it's something that has to be taken twice a day. I know that you may have heard of L-glutamine. You may have seen it in the store because it is amino acid. You can buy it in the supplement section. What makes the Indari different from what you could buy over the counter is basically the volume of medication that is required. So in order to take enough of the Indari that you would need to get this 5 to 15 grams, that is a significant amount of capsules that you would have to swallow. It would be in the range of 30 to 40 capsules per dose in order to get to a level that is what you would need for the protection that you're looking for in using Indari. So that's why it's best to go with a prescription version, because it cuts down on the volume of the powder that you would have to take. The next one that I'll go to here is Oxbryta. It's also referred to as Voxelotor. This medication is a game changer. It came out at the end of 2019, and I call it a game changer simply because it actually blocks the polymerization. It blocks that sickling process in its tracks. So if you can stop the red blood cell from sickling and changing into that crescent shape, then in essence, you have stopped all of the things that can happen downstream in terms of creating the blockage of the blood flow, in terms of the hemolysis of the breakdown of the cells. It's very, very, very important. So this is a unique mechanism of action that none of the other medications that are available carry. The claim to fame for Oxbryta is that it increases your hemoglobin levels. It reduces red blood cell breakdown. Increasing that hemoglobin level is so important. And you may think that, well, this one doesn't say anything about pain. Well, the literature is still, the clinical studies are still ongoing. The information is still developing. What we know now is that it increases hemoglobin levels. Intuitively, if we can increase our hemoglobin levels and we can stabilize the cells, then you would think that you would get benefits as far as reducing pain episodes from occurring. So we're just waiting for more studies to be completed. They have a few that are in process right now. We're just waiting on those studies to be completed so that they can confirm that, yes, there is a reduction in pain. But equally important as reducing pain is preserving organ function. What you saw Dr. Martin talk about in his slides in terms of all of the different areas, the brain, the heart, the kidneys, the lungs, all of those different areas that are impacted by the presence of sickle cells. If you are able to increase your hemoglobin levels, that actually confers a benefit of organ preservation. So for every 1 gram per deciliter that goes up for hemoglobin, every increment that goes up by 1, that actually confers organ preservation. So that's why Oxbryta is so important. This is a medication that comes in a tablet, pill, or tablet form that has to be taken by mouth once a day. The adverse effects that have been associated are listed there at the bottom for all of the options here. With Oxbryta, though, diarrhea, it's more of a prevalent one, but the diarrhea is basically associated with the dose. So the dose can be tweaked a little bit. It doesn't have to be exactly 1,500 milligrams. Sometimes if that dose is decreased, then you can eliminate that whole diarrhea and still get the same benefit that you were getting in regards to increasing hemoglobin. The last one that's available that I will talk about is Adakveo, crizanlizumab. This is a medication that reduces the frequency of the vaso-occlusive crisis in pediatric patients ages 16 and older who have sickle cell disease. What it does is that it binds to P-selectin. P-selectin is a protein that's on the inside of the blood vessel wall. And this protein, I call it like a catcher's mitt. What it does is that it's just sticking out of the blood vessel wall. And when the red blood cells come by, the red blood cells can get caught inside of it. So once that red blood cell is caught inside of it, it also begins to interact with other cells that are around. So when you get all of these cells basically in a group, we can get what's called a blockage. So therefore you have blockage of blood flow. What this medication does is that it actually binds to that p-selectin so that it doesn't form those interactions with the sickle cells and the red blood cells and all of the other cells that may be in the area at the time. It blocks that. So what it has shown is that there's a reduction in the frequency of pain episodes. There's a reduction in the days hospitalized due to pain. What makes this medication different is that it is an IV medication. So it is something that would have to be administered in a hospital setting. And it is something that you would have to, again, the dose has to be tweaked. But once you get to the dose that's stable for you, you can go to about a once a month treatment option. So these are these medications that I'm talking about now, the L-glutamine, the Artebrida, and the Dactio. These things have all changed the game of treatment options available for sickle cell disease. Prior to this, you heard me say late 90s was when hydroxyurea was around. You also heard Dr. Aguanaga say that sickle cell disease was discovered in the U.S. in 1910. So that means between 1910 and the late 90s, there were no treatment options for sickle cell disease. That's almost 100 years that have passed by before a treatment option was available. If that doesn't glare that there is a disparity in the healthcare system, I don't know what else could be. So 2017 comes and we've got a couple of agents that are available. And thankfully, because organizations like the NAACP are bringing sickle cell disease to the forefront and we're beginning to talk about it more, then now the light is being shined on sickle cell disease and more drug companies are putting forth the effort and more money is being devoted by the federal government to do research in this area for sickle cell disease. So I'm very hopeful about the future and what it holds for treatment options that are available for sickle cell disease. For any of these options that are available, if anyone needs questions answered in regards to how to get access to these meds, because that is definitely something that is another limiting factor. These medications outside of hydroxyurea are typically obtained through specialty pharmacy channels. You won't be able to find them at your regular retail pharmacy. So you will have to go through special pharmacy chains to get it. And if you need help with access, please feel free to reach out to me and I can definitely help you navigate that space. So going on to the next treatment option that's available for sickle cell disease is the bone marrow transplant or a stem cell transplant. This is the only curative therapy for patients with sickle cell disease. The cure rate is about 87%. The challenges with the bone marrow transplant are that it is limited in use. It's typically reserved for the pediatric patients who have severe disease. It is very costly. There is a risk of death associated with just going through the process itself. And it does require you to have a matched donor in order to even be a candidate. And even once you go through the process, there are severe adverse reactions that can happen post-transplant. So basically, a bone marrow transplant is when you have the marrow donated by a donor that has been deemed a match for you, your body undergoes a process of chemotherapy where your immune system cell line basically is eliminated. The donor cells are transfused into your body, and then your body starts to make new cells, which are no longer sickle cells. And I'll let Lucon speak more to that piece because she does have a personal journey to share in that regard. The next therapy that's available, that's still in clinical research right now, is gene therapy. You may have heard about gene therapy either on the news because 2020, I know, has done a couple of specials about it. There was actually a young lady at Centennial that actually went through the gene therapy process for sickle cell disease. And up till now, she has been deemed cured, but it's still in the research phases. It's not something that is FDA approved for everybody, but it is very promising. And in gene therapy, there's a viral vector that is used. You may have heard of vector. That's a common term that we've been talking about with the COVID virus, with the COVID vaccines, I'm sorry. So in the vaccine, there is a vector, which is a virus-based vehicle that delivers those therapeutic genes for use in gene therapy for sickle cell disease. So basically, the parts of the cell or the amino acid substitution that's wrong, it's actually corrected. So those cells are harvested from the person who has sickle cell disease. Those cells undergo the gene therapy process. Then they use a viral vector to transplant those cells back into the person. And then that person now, because those cells have basically been fixed, they no longer make sickle cells. So gene therapy is something that's very promising. I know I explained it very simple, but it is a very complicated, complex process that takes place. But just know that gene therapy is something that is very promising and has shown that it does work. We're just hoping to see that this is something that will be available to all patients once the time comes. So that's all I have for right now in terms of treatment options and therapies that are currently available for sickle cell disease. So I will stop sharing now and I will give it to Lucon.
Oh, dang. That came around quick. Oh, gosh. I'm so nervous, y'all. Can you imagine just driving
Don't
down
be.
the street?
You're among friends.
Huh? What's that? Can
Don't
you
be nervous.
imagine?
You're among friends.
Can you imagine in 90-degree weather and you're driving down the street and you see a child in a coat and long pants? That was me. My name is Lucon. I was diagnosed with sickle cell at the age of 16 months. So my entire life was spent in and out of the hospital. And of course with sickle cell, you get cold a lot. So other people be like, they're hot and you're like, I'm cold. So it was always a battle in the house when it came to the AC because the AC will make you have a crisis. Can't sleep under the air. Even swimming, same thing. If you don't dry off real good, you're going to go into a crisis. I've had to get several blood transfusions every time I was in the hospital. And as a result, it put me into iron overload. So then I had to go on another medication because my liver was failing. As a child, I missed a lot of school. So I had to repeat a couple of grades. And it was just basically because of my attendance. Okay, I wrote everything down. Blood transfusions help keep the crises, pain episodes under control sometimes. And then they put me on modified blood exchanges where they would take like 600 cc's of my blood out and replace it with donor blood. And so that went on for about 4 years. So for 4 years, I had maybe one or two hospital stays a year versus having 12 to 24 hospital stays a year. One thing that I wish I knew back then, transition from pediatrics to adults, is that you get treated totally different in the ER. As a child, they have you back within 30 minutes. Then when you become adult, it's like you're sitting in the ER. The longest I waited in the ER was 6 hours just to go into the back. And by then the pain is off the chart. So my pain protocol wouldn't work. And that's when you have to deal with the rudeness from the doctors saying, well, we gave you X amounts of morphine and Dilaudid, your pain should be under control, but it's not. I thank God for foundations like Breaking the Sickle Cell Cycle, because Demetria, she really advocates for sickle cell patients, and she's in the community doing various activities, because as a child, we didn't have resources like that. My mom she wasn't very knowledgeable of the disease, so she really didn't know what to really do for me besides give me Tylenol and have me lay down. She didn't know the importance of, she could have a stroke. You need to make sure you're taking her to the hospital, because I ended up having a stroke at 10, and she didn't know what was going on. She thought I was just faking. Oh, you're faking. You don't want to do chores today. I see. So, but I was really having a stroke. So, Breaking the Sickle Cell Foundation is truly dear to my heart. When I heard Lamitra's story on why she started the foundation, Breaking the Sickle Cell Foundation, because her son has sickle cell. And she goes into the communities because a lot of people don't know that they have the trait. And that's what causes people like me to end up with the full-blown disease. Because my parents, they weren't tested. I was born in 1977. So, there wasn't any medical research out then about, we need to trust you to do a test before you can have children. And that's one of Lamitra's main goals, to break the cycle, get people educated. And even with parents, new and old mothers of children with sickle cell, being able to get support for them, get them in support groups to help them deal with the child with sickle cell, and making resources known to them. And like with the different medications that's out now. So I really admire her for that. I'm going to fast forward. During the pandemic, Lamitra reached out to different families with sickle cell, making sure they had groceries, because they knew that they couldn't get out and get to the stores because of the risk of COVID with kids and things. So she sent them Kroger gift cards via email and in the mail. And she also did a backpack drive for kids. So we was boxing up backpacks, shipping them and sending them to different kids. And she had these little care packets in there, which had different little essential oils that helps with pain. So I got a chance to help her with that. And that was a big success. And the people who weren't able to come, we did door-to-door delivery. So she really, really goes hard for sickle cell patients. So I just want to thank her for that. I'm almost done, y'all, I promise, because I don't want to be on here long. But for me, as of April the 13th, April 13th this year, I was cured of sickle cell anemia. I got the stem cell transplant. Before I got the stem cell transplant, I had to undergo 13 rounds of chemo and radiation. So that's why I don't have no hair. So it's not that I wanted to cut my hair like this. It was part of the process. I'm still in the recovery phase, because the first 100 days after transplant are very crucial. Like right now, I'm battling a virus that attacked my immune system and my lower GI, and I have graft versus host disease, which is something I was praying I didn't have to deal with. That also attacked my lower GI, so I'm having to deal with that. And with the stem cell transplant, you have to go back to the doctor every day, so it's real tiresome. The process with the stem cell transplant, they don't tell you all the side effects of it. So I had to endure bladder pain, which I thought that was going to take me out. The pain was it hurted more than what a sickle cell crisis was. That's how bad the bladder pain hurt. So I had to deal with that for like 3 weeks. My counts kept getting low, so I had to get platelets, more blood every time I went to clinic. Then I had the issue where I was passing clots, but they were saying my kidney function was fine. It's just a whole lot. But I wanted to say, just take the whole transplant away, because there were days where I just wanted to give up, because it was like I was just tired. My body was exhausted, but the stem cells were still trying to find their way to where they need to be. And the hardest part for me was eating, because it's like I didn't feel hungry, but I had to force myself to eat. But I wasn't hungry. I didn't feel hungry at all, but I'm like, I haven't eaten nothing all day, so I have to eat. So that was the hard part. So having a great support team like I did, where my friends were bringing me food, cooking for me at home, and bringing me food to the hospital really, really helped, because I couldn't eat Vanderbilt's food. Hope don't nobody on here work for Vanderbilt. But I could not eat their food. I really couldn't eat their food. So having a good support system is very, very, very important in going through transplant. Because those days where I just wanted to give up, I would get a text message or a phone call with encouraging words, or a visitor was coming to see me. And I was like, okay, God, I hear you. You said you're not going to leave me. So I'm going to go through this process. But if I would have known this was the process, I probably would have rethinking the transplant and just stuck to getting the blood transfusions every month. But I'm glad I went through the process. And that is all I have. Thank you.
So, hello everybody. I am Joe Bonds, and I am a member of the Clarksville local NAACP branch. I just want to take a moment and applaud Lucon for that courageous story. I wish we had a button where we can do some applause or something, because that touched me deeply. And so I applaud your courageous and tenacity. And I know it must be difficult, but I will tell you that it's inspiring to hear you talk about it in such a way. So my prayers and my congrats to you for being so brave and courageous at the same time. So this portion of this forum, we will be entertaining questions from our panelists. Some of the questions will be given in this manner, and then there are also questions that have already been given in the chat. And so after we entertain these questions, at some point we will go ahead and reiterate those questions so they can be answered in a public forum. So at this time, I will begin the questions. The first question is, who does this disease mostly affect, and what age groups?
I will take that question, Mr. Bonds. This disease affects mostly minorities, African Americans, Hispanics, people of Mediterranean descent, and from Central and South America, and people from Saudi Arabia and India. This disease is genetic, therefore it can affect all age groups, and you are born with it. It's not something that you acquire or that you can get from somebody. It is not contagious. Thank you.
Thank you, Dr. A.G. The next question is, what are the signs and symptoms of sickle cell?
Signs and symptoms. Like
Mr. Martin.
Yeah, I can take this one. So I think this is why knowing your status, having great newborn screening is so important, because those signs and symptoms can be different for everybody. Everybody has different triggers. Everybody has different severity of their symptoms. Depending on what subtype you have with the sickle change, different areas of the body can be impacted more than others. And so really it's just about understanding your own body. That being said, in general, the most common thing to impact people with sickle cell disease is chronic pain. Pain that, again, the relation, whether it's lower back, whether it's chest, whether it's thighs, those places can change. and be more typical for certain individuals. But flares of just dealing with that chronic pain, again, it's very common that I hear people feel like they're cold, achy, and then just, again, the emotional impact that can take. But over time, you can begin to get things like strokes or things like kidney damage. And so the earlier you know your status, the earlier you have somebody who can follow along with you. Prevention, whether that's through knowing those triggers, things like hydration, things like getting on hydroxyurea, or, my God, as a baby being on penicillin or an antibiotic to prevent infections. All of these things are very, very important to just know your status. So if there's one thing that I want folks to leave here with, know your signs and symptoms in your body, but there's really nothing better than knowing your status, including trait.
Thank you, Dr. Martin.
Dr. Martin, I want to, before we go on, I want to piggyback on what Dr. Martin said. And I want to say this from the setting of a mom with a child who has sickle cell disease, because I was in that situation. I had not had a baby before, let alone a baby with sickle cell disease. So I get this question a lot. How would I know if my baby is having a pain episode? And through the infancy years and even early toddlerhood, kids can't really talk in terms of articulating what's going on with them. So this is why it is so important, one, for you to take the diagnosis seriously when they tell you that your child has sickle cell disease. And one, you have to learn how to watch for those signs. One, if your child, of course, if they have a swollen digit like a fingers, toes, it's called dactylitis. But it'll look like a bee stung your finger or your toe. And I'm saying this because my son had it. It was actually two of his digits, like the pinky finger and the ring finger. They were very, very swollen. And it was obvious that it wasn't something that was normal. And it's something that is very sensitive to touch. If you go to touch your baby and they start to pull away, then that could be a sign that there is something going on there. Also, if your child is no longer playing with things that they normally would play with, like little kids, they have those activity centers, and you have a mat sometimes that they like to play with toys on. If you find that your child is no longer engaging in things that they once found joy out of, and they're, that's coupled with the fact that they may be a little cranky, you've noticed that they haven't been eating or drinking as much, then those are all telltale signs that your child could be going through a sickle cell pain episode, and you need to seek help to get medical assistance. And if there's ever a fever, whether you're an adult or whether you are a child, anytime there is a fever with sickle cell disease, it is a not 911 like call 911, but you need to get to an emergency room very, very quickly. Because in sickle cell disease, and we didn't talk about this a whole lot, but sickle cell disease actually affects the spleen. The spleen is the organ that's responsible for filtering out bacteria from the blood. And when that doesn't function properly, it leaves the person exposed to infection. Sometimes a fever is the body's only sign that it's fighting off something. In early childhood years, before penicillin became the mainstay or became something that young children should take up until the age of 5, before that came into play, childhood mortality was very, very high from sickle cell disease. And that's because the pneumococcal bacteria is what caused that early childhood death. So that's why it's so important to take penicillin for the young children. And it's also super important for any child or an adult with sickle cell disease to seek medical attention if they develop fever.
Thank you, Dr. Scott and Dr. Martin. So the next question was addressed, but for the benefit of being addressed publicly again, so everyone who may not have heard it can hear it, the question is there a cure for the disease?
I guess since we're talking about treatments and curative therapies, as of right now, the only curative therapy is the bone marrow transplant. And I would encourage you all that are watching today to register with Be the Match. It is so hard for a person to actually be blessed enough to have a donor match. especially in the minority and the African American populations, to have a matched sibling to be able to donate to you is it's a limiting factor that eliminates this treatment option from you to begin with, because you just don't have a person that's matched with you. But if we get more people to sign up in the Be the Match registry, you could actually be the cure for someone with sickle cell disease. So I encourage you all to sign up for Be the Match. If you want any more information or additional information on how to do that, please feel free to contact me. I'm not a spokesperson for Be the Match, but I have a son who has sickle cell disease. And I know at some point in time in the future, that may be something that he would be interested in, but he doesn't have any siblings. So we're already, not candidates for that option because we don't have one. So we would have to depend on something like Be the Match.
And if I could piggyback on that now, because there was a great question, I think, gosh, was it from Tiffany Best? I'm trying to keep track of who are asking all these great questions. But somebody had a daughter who had a transplant and said, well, gosh, when would we think about it? And when I hear folks say, well, transplant is a curative option, why wouldn't everybody get it? Why can't we just cure sickle cell disease? And I do think that we're really close to being there, but a couple limitations about it. So I think, as you saw from Lucon's story, even being on the back end, I don't mean to speak for her, but just hearing what she was saying, going through transplant, she's like, gosh, did I really make the right decision? She's talking about things called graft versus host. And that's basically when the transplant, when the donor that has the healthy hemoglobin, when you receive that as somebody with sickle cell disease, you're not just getting the red blood cells, the new red blood cells. You're getting everything, which means somebody else's immune system too. And if that immune system is not matched, when we talk about Be the Match, if it's not matched up with you very well, it can start to attack your own body. And so that's why why it's so important for people to register for Be the Match. Among people with Black and African ancestry, there's the greatest diversity. The dawn of civilization started in Africa. So, this time scale of diversity. And when you look again, whether it's from choice or enslavement, the geographic distribution of people who today, just because of their skin color, identify as Black, that diversity is huge. So when we're talking about, getting at somebody who's going to be a genetic match for you, it's really hard because we're just using, race or Black skin color as a proxy for what's actually a huge amount of diversity. So we need people to be matches, but we do have a new technique called haplotransplant, which means half match, and that's where people like your siblings could potentially be your donor, and that's helping as well. But to limit that toxicity, to limit those harms of the donor attacking you, we really need to get that match close. And unfortunately, even though we're making a lot of good progress, it's still not there yet. And that's to answer Ms. Bess's question, which is, again, why don't we do this for everybody? Well, if you took somebody whose disease was perfectly controlled, they weren't having any problems with it, they're actually doing pretty well with sickle cell disease, and then we do a transplant for those folks, we could actually cause a lot of harm if the match wasn't right. They could suffer some consequences from getting the transplant. So unfortunately, we're doing it mostly in people who their disease is getting so bad to the point where we're willing to take that risk to say, gosh, if we don't intervene now and cure this thing, this person may not be alive in the next 5 or 10 years. So we have to take action. And as the technologies get better, as transplants get better, as other experimental therapies that might have curative potential, something called CRISPR, as some of these other things get closer and closer, we may be able to start curing people with less of those side effects and be able to do it earlier. But one last point I want to make about this, which is that this cures the person with the disease, but it doesn't necessarily feed that cure forward to their children and their children's children, because we're not changing the whole body. Specifically, we're not changing when Lucon got the transplant, we didn't change her ovaries, the eggs in her that she could potentially give to her children. We just changed her blood with the transplant. And so even though we're going to have these curative therapies, and we don't want to really touch anything regarding eugenics or, you know, changing the children or that people could have, that's really potentially unethical and dangerous. But there's going to be a middle ground here where we can cure people. But again, why it's always going to be important to know your trait or your status early as a newborn, because even if mom or dad got that transplant or got that curative intervention, you as their child could still have the disease. And so knowing your status is really important.
Can I interrupt here? So when my daughter received the transplant and the combinations of the radiation, chemotherapy drugs that she had, the doses were so high that to this day she cannot have children, to the point that we probably should have removed and froze her eggs so that at some point in time she could have, you know, had children later on. But that was never discussed with us. But of course, you know, we found that out later. But because of her chemo and radiation combinations, yeah, she can't have children at this point.
I'm so sorry to hear that, you know, and that is something that, yeah, that's not an uncommon story. And to Lucon's earlier story about her bladder, one of the medicines we do use, something called cyclophosphamide, can cause kind of bleeding irritation of the bladder that can be very painful. So some of these things that aren't necessarily the transplant product, but the chemotherapies that we do as a part of the transplant can really have some additional lifelong, both short but also long-term damages, and infertility can be one of those. Importantly for anybody else on here too, hydroxyurea can also do this for men. I'm not sure to the extent that it does it in women, but can cause something called azoospermia, or low sperm counts. And I actually have a few patients who have had this, and is one reason I'm trying to get them onto these newer therapies like L-glutamine that Dr. Scott spoke of. So even the non-transplant treatments that we have can have, you know, pretty dire consequences with family planning. And so it's just important to really listen to your patients, take a very comprehensive approach, and not, again, just not be thinking about the sickle cell disease, but what the person's dreams, goals, what they're trying to accomplish in life is, and really respect each person and each patient as a human being.
Thank you, Dr. Martin, Dr. Scott, and Tiffany as well. This next question, I'm going to two-part it. So what are some of the effects that this disease has on the body, painful or otherwise?
You know, I was just going to say, I would actually have our Dr. Scott, and again, maybe even Lucon, because I think hearing from people who can say what had happened, I mean, my gosh, I had never heard about how a parent would, in a non-communicative early child who maybe, you know, less than 3, what to really look for. I learned something I'm going to remember for the rest of my life tonight because of that. So I'm going to just let Dr. Scott, and I'd love to hear Lucon share her story, or even any other people on here who have sickle cell disease.
I want to highlight one, I guess you could say from a male perspective, this is something that is oftentimes overlooked, and it's priapism. Blood flows all over your body, including the penis. So when a male experiences priapism, oftentimes he may not share that information because of it may be assumed as embarrassment, or people just may not understand, and they may label this person as, you know, being a perv or something to that degree. But sickle cell disease actually can cause a hardening of the penis that is that causes excruciating pain. And this is also something that could be a medical emergency if it's not taken care of within about 2 to 3 hours max. If it's not going down and the pain is, you know, continuous, that's something that needs medical attention. It is not something to be embarrassed about. It is definitely something that needs to be discussed. Well, I know we always talk about pain in sickle cell disease, but pain shows up in a variety of ways.
Well, with me, some of the things that I've experienced, like I was saying, the strokes. I've had 2 strokes in my life. And sickle cell, it affects your joints too. I've had 2 total hip replacements as a result from the sickle cell.
Thank you very much for adding that.
One other thing that I would say again is there are some of these signs and symptoms which people can feel. There are other things which may be silent until they can be too late. And particularly, I mean, things like back of the eyes. So
Yeah.
over time, people can get blindness from, again, just the back of your eye there requires a lot of blood. And also the lungs and the heart over time, something called hypertension or high blood pressure of the lungs. And that can be really devastating too. So it's just really important that in addition to the things you may be feeling, you may be under really good control, thinking everything is fine on your hydroxyurea, having few pain crises, but it's still important to follow through for those routine checkups and make sure that 5, 10, 15 years down the road, and I hope that we have a day when most people are just down to that routine care, but we have to make sure all those other things are getting checked up as well.
Thank you. Do anyone have anything else to add to that topic? Okay, moving on to the next question. Is there any early screening for the disease at birth or in the womb?
I will take that question, Mr. Bonds. Yes, indeed. In the state of Tennessee, since the fall of 1989, we had universal newborn screening for every baby born in the States, and that included sickle cell disease. Right now, 50 states of the union test for sickle cell disease at birth. So also at the Meharry Sickle Cell Center, we perform a lot of community screenings, and these are free, and many times we have done them with otoscope, and we test adults and teenagers that come to the community screenings. And sickle cell disease can also be detected before birth. It can be detected prenatally, and there are different types of tests. You may have heard about amniocentesis around 16 weeks in pregnancy, or chorionic villi sampling between 9 and 11 weeks of pregnancy, or isolation of maternal cells or fetal cells from maternal circulation, which could be done also by 11, 12 weeks in pregnancy, and percutaneous umbilical blood cord testing, several tests that can be done during pregnancy, and most recently, we have what is called NIPT, non-invasive prenatal testing, that all it takes is a blood sample, and it's based on the fact that some fetal cells circulate in the maternal blood, and this can be isolated and tested by getting specific types of DNA. More interestingly, there are tests that can be done in embryos, and that's called pre-implantation genetic diagnosis. For example, if a couple that has the sickle cell trait is contemplating having children and they want to circumvent the issue of a pregnancy with sickle cell disease, they can go ahead and subject themselves to this test. And it requires in vitro fertilization. And then once the eggs are fertilized, they are put in incubators, and about 3 days later, they are taken out and a biopsy is made. And then it can be seen which embryos have normal globin genes and which embryos have sickle globin genes and which embryos have sickle cell trait globin genes. Then those embryos are reintroduced into the mother, and if pregnancy is achieved, then a baby will be born disease-free. Thank you.
I would like to ask a question.
Is there anyone else that want to add to that?
I have a question that I would like to ask, and this is in regards to the testing. So although you are testing people for sickle cell disease, how is that communicated and how is that followed up on in your meetings with your patients? like when you follow back with your patients, are you like really going into details about the dangers of sickle cell disease and selecting partners? Like if you're a pediatric physician, I'm not sure if you guys are pediatric physicians or if you're just treating adults, but do you continue that conversation with your patients so that we're not having babies born with the disease?
Yes, Ms. Bess, that's an excellent question. Actually, at the Sickle Cell Center at Montgomery, we have a strong follow-up program. For example, if we identify a baby with sickle cell trait, immediately we contact the family. We send the results to the family pediatrician, to the state of Tennessee newborn screening program, and we send the family a letter explaining what sickle cell trait is. And then we call the family and go through the letter and go through any questions they may have. Moreover, every time we find a trait, we pay close attention. And we ask for the partner to come and be tested. Because if you have one of the partner with sickle cell trait and you don't know what the other partner has, definitely you are at high risk of having a child with sickle cell. So we do that. In many instances, they don't come to have the partner tested. In many other instances, they do come to the center and we perform the test for free. I am a clinical laboratory scientist. I am not a physician.
Okay.
Mainly I work with blood and I also do research. And in the case of sickle cell disease, the system is different. Once we identify the baby, we refer the baby first to Montgomery Pediatrics to have a baby's first visit, and we counsel the family and we educate the family about the disease, about the symptoms, what things are key to watch out, because like Dr. Scott mentioned, you know, you just had a newborn and you don't have any clue to know if your baby has pain or if your baby is having a problem. So we go through those. Then Montgomery refers the sickle cell newborn to a specialty clinic, usually a tertiary center, Vanderbilt University or TriStar Children's Hospital. Sometimes the parents already had a child, an older child with sickle cell, and they are going to Centennial, so they want to have all of their children seen there, so we will refer them to them. And then once that happens and the baby is put in the hands of a pediatric hematologist, then we can close the case with the state. But still, we keep in communication with the tertiary center, getting the clinic notes, and making sure that the baby is seen at least every 3 months, the first 2 years of life, and every 6 months or earlier if needed during the following years of life. So that's how we do. Now, I cannot emphasize enough the importance of community screenings. We have had community screenings where we have identified mild cases of sickle cell disease in an adult person who had no clue that had sickle cell disease, who had never been to the doctor. So I cannot emphasize the importance of participating in sickle cell trait screenings, and also especially in people of reproductive age that are considering having kids. And this is irrespective of education. You can be well educated like Dr. Scott and her husband, and they have no clue.
Yeah, and actually, I would definitely agree with that. And that's what I have kind of found just in the different works that I've done with sickle cell. And that is how uneducated people are. And that is the adults who are very uneducated about the disease, to the point that the information is not being passed down to our youth who are, you know, having sex, you know, with people not knowing their statuses and, you know, ending up with children, you know, with the disease. And in my case, you know, that was, you know, I was a teen mom, and sickle cell disease only mentioned, yeah, that runs in our family, but never any conversation about it. And so it really did not hit home until I had a baby that had it. So in terms of like education, you know, community education is just so important. And, you know, getting into the school systems, you know, I don't know if they still teach health in, you know, certain areas, but I'm not from Nashville or Clarksville. I'm from St. Louis, but having advocates where that information is taught or discussed to some degree, in schools is definitely important and something that probably should happen to decrease the numbers of births.
Absolutely. That's a population that we need to pay attention to because we have a lot of teen pregnancy, as you know. And these babies have been tested because the first babies that were tested, at least in the state of Tennessee, now are, 32 years old. And many, while being teenagers, were having babies and didn't know their status, even though they had been tested. And they go back to their mother, and the mother doesn't remember what the baby result was, It was many years ago, they don't remember, or they didn't keep the letter, or they didn't keep the information. So that's a population that I have particular interest on, young population, reproductive age, teenagers that may be having kids and they may have the trait and they have no idea they do. Thank you for bringing that up. And Dr. Martin.
Yeah, I just wanted to say, certainly I think this is such a good question, and there are some other questions too that if there's interest, we would love to do encore talks, really digging into these areas of what we envision for the 21st century and areas that we need to improve upon. I think that the pediatric to adult transition is a huge area. I think there's been several stories here, both in folks who've shared in the chat, of things that have happened to their children who transitioned, and they're still seeing pediatricians where the care may be better, or they feel like there's more rapport and established folks who know them. But also, Ms. Cooper had a similar experience, and I saw a lot of people nodding when she mentioned the changes in how she was treated in the ER when she was in pediatrics to adults. So lots of things we need to do there. But trait outreach is another big area, both for making sure that kids who are newly identified today and their families really understand that that's a status you want to know, even if it's not manifesting, even if it's not having symptoms right away. You're going to want to know that. When I think about, I think as Dr. Scott brought up, 1 in 13 people of Black or African ancestry are going to have trait. 1 in 365 with sickle cell disease, or the SS, but 1 in 13 with trait. So what I think about when I hear that number is a classroom, about 26 kids per classroom, give or take. That means for every classroom, there's 2 kids in there, especially in, Black neighborhood schools, 2 kids or so who are going to have trait and don't even know it. That's a huge amount, every single classroom in America. And so, yeah, we have a long way to go into making sure that all of those children out there, all of their families understand their trait status. And one of the other reason that I'll just inject into this, and again, hopefully we can share this in future conversations too, about, again, social justice, disparities, historic racism within this disease. There's a big New York Times article that just came out several weeks ago talking about how police officers or police departments were using trait as a cause of death for Black men and women who, I can just say the facts of the case did not appear at all that trait was a cause of death. Much more likely to have been some type of intervention or interaction with the police. And so again, knowing your status, being able to not let somebody else label you or define you, but really taking ownership and having some agency is important. So for many, many reasons, family planning, social justice, and really just making sure that, again, the athletes and people who are high functioning, they may die of trait as well. And so this is just something that, needs to be accepted, not stigmatized, accepted as a norm. And there needs to be, hopefully with doctors like myself and a community of physicians and pharmacists, we need to make sure when you know your status that you're supported, right? Knowing your status doesn't mean anything if there's not community resources or people that have your back that can help you out. Knowing your status just to be left hanging just leaves folks disillusioned. So we need to do a better job having the resources available for those folks too.
Thank you, Doctor. I appreciate it. So in the appreciation of time, we have about 10 minutes, or about 9 minutes remaining. So we're going to entertain one more question, and then we're going to let Dr. Scott tell a little bit about her organization. So, Mrs. Franklin, if you would, please go ahead and make your comment or ask your question.
Thank you, Mr. Bonds. It's more of a comment. I've had the pleasure of working with Dr. Aguinagua for about 10 years at the Meharry Sickle Cell Center as a genetic counselor, and the question about whether or not individuals know their trait status, if they understand the inheritance of sickle cell, and making sure that conversation happens in the family, and making sure that young people have that information. This conversation has not changed since I was at the Meharry Sickle Cell Center. It hasn't changed since the early 70s. And so this is something that we have to continue to champion. I will say this about genetic counseling and allowing individuals to make their own choice, whether or not, with regards to family planning. On the other end of the spectrum, there is eugenics, which is real, particularly with people of color in our country, and that choice about family planning being taken away from us. And on the opposite end of the spectrum is also about being informed about the chance that you could have a child with sickle cell disease. So regardless, the bottom line is that we have, as the NAACP, and I'm the state health chair for Tennessee, but we have to continue to make sure that this conversation does not rest after this talk today. This is something that we have to continue to champion year after year, month after month, day after day. Thank you, Mr. Bonds.
Okay, at this time, I will turn it over to Dr. Scott to speak a little bit about her organization, and then I will give it back to Mrs. Layton.
Thank you, Mr. Bonds. I just wanted to do a quick shout out to Breaking the Sickle Cell Cycle Foundation, I'll say. I started the organization back in 2015 for reasons that we're talking about right now. I was not aware that I had the sickle cell trait. I was not aware that my son's father had the sickle cell trait. There were not conversations being had in our families that this was even a possibility. So the name of the organization, Breaking the Sickle Cell Cycle, the mission is to promote awareness, education, and prevention of sickle cell disease. How do we prevent this? How do we break this cycle? We can only do this through education. So the goal for the organization is to partner with community organizations like the NAACP, our local churches, schools, colleges, whoever will listen. That is where I go to talk about sickle cell disease. And working with the Meharry Sickle Cell Center, I'm actually able to offer that sickle cell trait testing after every presentation or wherever we show up. That's basically something that we do in the community, is to provide sickle cell disease trait testing. Because unless you've been tested, you can't honestly say, no, I'm not a sickle cell trait carrier. In addition to providing that education out in the community, we also partner with other healthcare organizations, because you would be surprised the number of healthcare professionals that are not aware of sickle cell disease or even how to treat it. So that opens up another can of worms for another day, but it also alludes to the fact of the disparities that Dr. Martin was talking about. So I just want everyone to know that if you're out there and if you have sickle cell disease, or if you're interested in being trait tested, please feel free to reach out to me, and I will definitely get you connected to who you need to be connected with. If you need help with resources and how to gain access to some of the newer therapies that are out there and available, I can help you with that too, because it's not an easy task to navigate in that space. And I will lead to Lucon, because she works very closely with our organization, and she can speak better than I can to what Breaking the Sickle Cell Cycle Foundation means to her.
Okay, we have 5 minutes left, and I wanted to go ahead and acknowledge Ms. Shamika Jackson. She was another one of our guest speakers, but she just got out of hospital, so I didn't want to put any pressure on her. So I just wanted to wave and let her know that we're praying for her, and we're glad to see you out of the hospital. All right, so I want to come back and do a part 2 of this sickle cell health forum because we got a lot of information and it seems like there's more information that you all want to put out as well. And it's a lot of good information. I'm glad we did this forum because it drove me to go and get tested for sickle cell. So hopefully all of you on this panel will go out and do the same. But I just want to say this concludes our sickle cell health forum, and I would like to thank all of our panelists on behalf of the NAACP, Clarksville, Montgomery branch 5582. I just want to thank you all who came out, all who participated, and all who was here in spirit, Ms. Shamika. And we're about to shut off. The Zoom is going to shut off in like 3 minutes. And if you guys want to have a quick discussion in the last 3 minutes, we can do that.
I just want to, again, just say how honored I am to be a part of this conversation and a part of this community, and look forward to ongoing conversations on how we can partner together to look for cures, to help people plan their family and know your status. So thank you so much for inviting me.
Thank you guys for having me.
Okay. Well, this concludes our forum. I want to thank everybody for coming out. God bless and good night.
Good night, everyone.
All right, until next time.